We'll give a couple of minutes for others to join the session, and then we'll get started today. Good afternoon or good morning, depending on where you are joining us from. Thank you for joining us for our March MPRINT Hub webinar. Today's webinar is going to be presented by Dr. Julia Phillippi, who joins us from Vanderbilt University. Julia is a certified nurse midwife who is also a practicing clinician and helps to make research available to using prospective and retrospective approaches, to look at midwifery health services research to explore topics relevant to child and maternal health. She has graciously agreed to present our webinar today on the power of maternal characteristics on perinatal outcomes, potential co-founders for perinatal investigation. Dr. Phillippi, I'll pass the microphone to you. Thank you.
Okay, thank you. Can you hear me? I just want to make sure that my sound is still working. Okay, wonderful.
Yeah, you're good.
Just a little note on the title. So I will tell you that I am not great at naming things. It's one of my least favorite tasks. In fact, my third child, we actually brought home unnamed because I couldn't pick a name for him. So with the title, we made this title a few months back. And then as I've been making the slides, I've kind of adjusted what I'm going to talk about a little bit. So I'm not going to just talk about maternal characteristics. I'm also going to talk about fetal characteristics and health system characteristics as well. And we're also going to talk about more than just confounders, because some things are not full confounders. There are other lurking causal variables, but they're still really important for us to consider as we're crafting perinatal research. So because we haven't been able to be all together in one space and introduce ourselves, I want to tell you where I am in the whole MPRINT scheme of things. So I'm part of the Vanderbilt version of MPRINT with the Vice MPRINT. And in that, I am on project 2, which Stephen Patrick is the PI on that. And then within that project 2, I am really focused on AIM-1. But don't worry, it's not just about AIM-1 that I'm going to be talking about. I'm going to be talking about things that are a little bit broader than that, all of perinatal care. Often in perinatal research, we have these teams that are working together, and we each have totally different views of the problem or totally different skill sets. And that's great because it makes for fabulous synergy, but it also means we don't always have the complete picture of what we're studying at the time. And you may be thinking, why do I have an elephant on the slide? But bear with me. When I think about how great the teams are that we have with MPRINT and how we each have different expertise, I think a lot of the ancient fable of the blind man and the elephant. So these individuals, they encounter the elephant, but they only get to experience a portion of the elephant. So when they get back together, they have very different ideas as to what's going on or what needs to happen. And I think just like in the fable, we all have expertise in different realms. And right now with MPRINT, we're encountering really large problems. And we might not be seeing the whole of the problem. Like it's really difficult to hire people who not only have expertise in healthcare, but they also have expertise in data and databases and how to get data back out of databases and clean it and then construct mathematical models. It's hard to find someone who can do all those things. So in many respects, we all only have a piece of the elephant that we understand. But by dialogue, like for instance, these webinars, we can start talking about things that are important within our realm of the elephant and hopefully get a really good sense of how to craft really solid questions and then how to get data out of the databases in a way that provides meaningful answers for healthcare moving forward. And I have a great example. Just on Friday, working on project 2, we have Friday afternoon meetings. I love spending Friday afternoon with that team. And the people from the phenotyping core had done some initial polls on the data, and they said, oh, this is problematic because only about half of the individuals giving birth in this data set have information on the gestational age of their fetus. And as a practicing clinician, I take just a wee bit of call to stay current in that zone. I was like, oh no, it's like it's on every birth record. It's like on every note I make, it auto-populates. And so by talking with them and showing where the data comes from, because then someone said, oh, if it auto-populates, it's actually in a different spot. So let's go find the spot where you enter it. So then we go to where the data is entered, and we never actually key in gestational age. Instead, we key in some other measures that then it calculates gestational age for us. And some people have their estimated gestational age on one factor and other people have it on their ultrasound. And so we were able to really drill down to what the problem was with the data and then be able to go to the more meaningful field rather than the field that we thought we were going to easily use. So I think this is a great way of talking about some pressures in perinatal research that not everybody would know because they just don't encounter them on a regular basis. So I have some notes on terminology because of course we're coming from very different lingo lands. And so I want to explain some of the words that I'm using. So I'm going to try very intentionally to use the word pregnant people. And you can correct me in the chat anytime I use the word woman or women, unless I'm specifically talking about that subgroup of individuals. And the reason for that is not all pregnant people identify as women. So I'm trying very hard to change that terminology to be more inclusive. I'm also going to use the word perinatal. And today, what perinatal means for us in this discussion is anything having to do with pregnancy, labor and birth, or postpartum for maternal outcomes and neonatal outcomes and care. And I am going to use the word maternal in part because there's not a concise and accurate term to use instead. I'm hoping that we come up with one, but that one is still in wide use. And I do recognize that not all people who give birth recognize themselves to be women or maternal, and many people who give birth aren't going to parent that child either. So with those caveats, here's some of my terminology. And in looking at the word confounding, that people use that word in different ways. And so here, what I'm using that word to mean is a distortion in the estimated association between an exposure and an outcome related to a factor that acts both on the exposure and the outcome. And the reason for that is that that is the way confounders are defined. A lot of people use the word confounder to mean other lurking causal variable that might not act on the exposure. And I'm going to try and be clear about what's a true confounder and what's not. But just in speech, I think we often mix those up. So the classic example of a confounder in perinatal care is the rate of live births where the infant has trisomy 21, strongly associated with birth order. So if that baby is a first baby or a second baby or third baby, the more babies, the more siblings a child had ahead of them, born to the same mother, the more likely that child is to have Down syndrome. It's a nice, strong association. However, there's a lurking causal variable, right? Maternal age is a confounder for that. And that maternal age actually has a stronger amount of power on that outcome. It's more causal than just birth order, right? So that we have to be careful as to which variables we're picking to make sure that we're getting meaningful data. There is a huge need for research with and about pregnant individuals. The health and pregnancy affects the lifetimes of at least 2 individuals. Sometimes there's more than one fetus, right? And particularly, and even their later progeny due to epigenetic changes, and then also health changes that occur in the perinatal period that persist and cause changes in socioeconomic status, right? And about 4 million individuals give birth in the US every year. So this is really happening. Like this isn't just a rare condition, pregnancy isn't. About 75% of drugs approved by the FDA in a 10-year period from 2000 to 2010 had no data on safety in pregnancy, and 97.7% of them had undetermined teratogenic risk. The majority of drugs on the market today do not have clear data on effects of pregnancy on drug effectiveness or risk to the fetus. And that's just a sampling of like exposures, right? Drugs are one type of exposure. There's other exposures too that we have even less information on because they're not approved by the FDA. And with drugs, a rising percentage of pregnant people have chronic conditions that require some sort of medication during pregnancy or some sort of medical intervention during pregnancy. So we're having more and more pregnant individuals that are having exposures that we don't really know what effect that has on their health and what effect that has on their fetus's health. So one of the reasons why we have so little data is that in 1977, the FDA stated that individuals who were pregnant, or had childbearing potential should be excluded from early clinical trials, and that pregnant people were a vulnerable research population that required strong protections in advanced clinical trials. Now that made sense at the time, right? We had just gotten through thalidomide and some other really bad scenarios with pregnant individuals that had long-term repercussions and deaths. However, it meant that all research basically stopped. Those regulations were loosened in 1993, but still research that includes pregnant people and perinatal research is way lagging behind the research that's done with non-pregnant people. There's a big movement right now to redo the status of pregnant people in research. So in calling them vulnerable, that meant that they were prone to coercion is how that term is often used. And there's a big move to redo that so that we're not thinking of pregnant women as more prone to coercion than anyone else because they're adults with full capacity, but instead that they are scientifically complex and they need greater attention to and greater levels of consent on risks and benefits than non-pregnant individuals. And it's super important that we get research moving with pregnant people included, because not letting people into research influences their health, right? If we exclude pregnant people, we may actually be worsening their health, not only long-term because there's not data, but in that moment. So for instance, with the HIV trials, in the beginning, they excluded pregnant people from HIV trials, and that didn't really work well. My mom has this saying, my mom has these great Southern sayings, and one of her sayings is, if mama ain't happy, ain't nobody happy. And you can kind of redo that to say, if mama ain't healthy, ain't nobody healthy. If you aren't giving HIV treatment to a pregnant individual with HIV, that was actually making that person's risk of death go up. And if they die, their fetus also dies, right? So we were actually worsening health by not letting people come into those trials. And if you can think about the same thing with COVID vaccination, right? The risk to COVID vaccination that are unknown to the fetus versus the real risk of death due to COVID, and pregnant people are at particularly increased risk of death if they acquire COVID in pregnancy. So we need to be open to the fact that with informed consent, pregnant people could be welcomed into trials that are not specifically about pregnancy even. However, there's issues to that, right? Like pregnancy in itself can affect drug response, can affect response to various behavioral interventions, right? And those individuals who are pregnant within the database may need to be analyzed separately, and sometimes that causes some sample issues. In addition, it can be hard to recruit pregnant people. They don't often hang out in the same medical zones as non-pregnant people. And it can be difficult with rare exposures in a fairly rare population in your sample to track outcomes with them. And then also outcomes of perinatal exposures, particularly to the fetus, may not be apparent for years. The rate of congenital malformations known at birth is one rate. It's about 2%, right? 2 to 4%. And then the rate of congenital malformations known at age 4 is much higher because we've had more time to see how that child does, right? And it's not just malformations that we're interested in, right? It's overall function. And sometimes that can be really hard to measure. So ideally, what we're going to do is, instead of relying on RCTs with pregnant individuals, we're going to use large data sets, right, that have links between infants and their gestational parent that are really helpful in studying long-term outcomes with data that was collected during the perinatal period. And hopefully that'll have us, let us have more precision as well, right? That's one of our goals. So when we think about precision, there's some interesting aspects of pregnancy to think about when we're looking at our research questions and when we're looking at data that we have available. So in pregnancy, there's really two bodies housed in one, right? Which I'm totally comfortable with as a midwife, but my friends in the ER, ooh, they don't like that. They don't like to, a patient within a patient. But that's important to consider because in thinking about drugs, for instance, sometimes these are talked about as compartments, right? You have the maternal compartment and the fetal compartment, and they're separated by placental tissue, which is kind of a series of membranes. That placental tissue can influence drug concentrations. So you can have higher concentrations in the fetus or lower concentrations in the fetus than the gestational parent. And that's important to consider, right? Also, pregnant individuals have high levels of key hormones that you don't really see in regular people, right? They have lots of progesterone. That progesterone has a lot of effects in the body, right? It prevents smooth muscle contracting. It's really good when you're trying to keep a fetus inside a uterus, right? Not so good when you're studying constipation, for instance, as a side effect, because constipation and pregnancy, they kind of go hand in hand. Also, pregnant people have lots of estrogen, like more than 20, it's the equivalent, I think, of taking over 20 birth control pills. That's a lot of estrogen, and estrogen affects blood clotting. So pregnant people are in a hypercoagulable state, which can change if you're studying, say, clotting with a trial. Pregnant people also have greater blood volume. They have practically an extra liter of blood, pretty amazing. And they have different, they have altered ratios of those blood components. So they have more plasma and less red blood cells compared to, like the average Joe on the street, because pregnancy intentionally changes those, right? That extra blood volume makes their heart work harder, right? Their heart is having to pump more in order to circulate that extra liter of blood. In addition, it makes some really cool changes in their veins so that their veins dilate so they can hold that blood in their veins. But venous capacity can also influence clotting, right? So you can see how there's a lot of changes in the pregnant body. Pregnant individuals also have an altered immune state because if you think about it, they have really kind of foreign tissue hanging out in their uterus, and you don't want them to attack that foreign tissue. So that does mean that their immune system behaves a little bit differently. And for instance, their white count, their count of white blood cells in their blood does not respond as quickly to infection as, say, a non-pregnant person. Pregnant people also have a metabolic profile that's really, I think, kind of cool, but it varies across pregnancy. So they have these physiologic low blood sugar levels in early pregnancy, which is thought to be protective for the fetus because high blood sugar can be teratogenic. And then over the course of pregnancy, their insulin resistance increases so that they actually have higher blood glucose that lets the baby take some blood glucose and kind of build up bulk in the end of pregnancy. But that means that even over the course of just a few months, right, their endocrine profile changes quite a bit. So if we think about some potential confounders, and I'm calling them potential confounders because sometimes they act on both the exposure and the outcome, and sometimes they're just acting on the outcome. Some things to think about are age. We're going to revisit age on a later slide because it's something that really kind of requires a deep think now. How many times they've been pregnant and how many times they've given birth before can influence some outcomes, some health outcomes. And their pregnancy outcomes are really important to know. My husband is a mathematician, so sometimes we end up talking about like mathematical things at home. And there's that whole Bayesian concept that the more you know, the better prediction models you can build, right? Very true with prior birth outcomes, right? If an individual has a cesarean with their first birth, they are more likely to have a cesarean next time. If they've had 2 cesareans, they're even more likely to have a cesarean again, right? Same with vaginal birth. If a person has had a vaginal birth, that's predictive of having a later vaginal birth. It's also predictive of some urogenital outcomes. So knowing a lot about that can be helpful if you're studying outcomes that might be, that you want to see how much power your exposure has on that particular outcome. You also want to be careful that you're incorporating or controlling for their prior birth history. Also important to know is their gestational age at the time that their labor started and when they gave birth. So if you're studying preterm birth, for instance, which we are all really wanting to prevent, if you have knowledge that they've already given birth preterm once before, that's important to incorporate. Other potential confounders, if you're trying to incorporate pregnant women in an existing research study, particularly when not focused on perinatal care, is the point in gestation you're doing those measurements, right? Because we talked about how endocrine change in metabolism changes over the course of pregnancy. Same thing with hormones. You're going to find different hormones at different points in pregnancy. Same thing with blood volume. You're going to see that blood volume rise between 16 and 20 weeks of pregnancy. So it won't be there in early pregnancy. Other things to know are the number of fetuses in her uterus. That's an important confounder as well. Maternal health status is just super important as a predictor for later outcomes. If an individual has comorbid conditions, those comorbid conditions often exert a lot of power over her birth outcomes, not only from that health condition, but then from the changes that her providers do to her care based on that health condition. So for instance, if she comes into pregnancy already hypertensive, she's not going to go past her due date. Most providers are going to make sure that she gives birth ahead of her due date. Body mass index is a big factor that we're finding out exerts considerable power on physiologic labor processes and causing them to be a little bit different or a little bit slower than usual. So we want to make sure we're controlling for that. Fetal health status, also super important. It's definitely a lurking confounder. And one thing that we're seeing more and more of is knowledge of genetic differences, right? So this little bit here, this little baby on the slide has a cleft lip and palate. That could be genetic, right? Or it could be not genetic. And it used to be, when I first came into practice about 20 years ago, we wouldn't really know genetics unless there was something really wrong with the baby and we sent the baby off to a geneticist. Now with fetuses, because of non-invasive prenatal screening, where we can take the pregnant individual's blood and actually find fetal chromosomes and fetal genetic data within the gestational parent's blood, we can actually do tests on the fetus and know a decent amount about their genetics prior to them even being born. And so that's something that we should consider as we look at database research, is how much we're going to use that data, and whether it's a big deal or not that portions of our population have that data and portions of our population do not, and it's not random as to who has that data. So fetal health status is really important. Genetics leads to morphologic alterations as well. So you can have a child with very normal genetics that has a morphologic alteration, so has a cleft lip and palate, or you can have a child that has a genetic disorder or some sort of genetic difference that is leading to that cleft lip and palate. Another important thing is overall fetal health. And I just today got a Google alert on a study that used a big, huge Swedish database to look at perinatal outcomes by gestational age of birth, right? And they had 36, 37, 38, and 39 and 40, right? All those ages. And they said, oh, there's a problem with babies that are born at 36 and 37. They actually have higher rates of all these conditions, but they hadn't controlled for fetal health status, and they hadn't controlled for whether the gestational parent had gone into labor spontaneously or had been induced. And fetal health status, if the provider sense that the baby has something that might lead to stillbirth, a lot of times they're inducing ahead of time to get that baby out so that the baby can get medical care on its own. So that's a confounding variable for gestational age, right? There's this pressure of the fetal health, so the providers are more likely to induce labor. And so that's why we're seeing those increased risks of bad outcomes at those gestational ages. It's not just the gestational age in itself, but there may be another variable about the fetus's health. So there's a lot of decisions to be made when we're doing perinatal research with large data sets or prospectively. And these are just some things to get you thinking. It's not a comprehensive list, but think carefully on demographics. So when you think about the demographics of people that you're collecting, what do you mean by demographics here? Do you mean the gestational parent? That gestational parent may not actually be related to the fetus that they're carrying, right? Because we are now seeing more and more individuals using egg donors, right? So they may not have a genetic tie to their fetus. And that's important to think about if age may be a confounder for you, right? And if we think about the demographics of the fetus, a lot of times fetal demographics are noted to mirror maternal demographics, right? Or the gestational parents' demographics, or even the egg donors' demographics, right? But the fetus has two parents who may have very different demographics. So that's important to think about as to whether that's important, and you need to drill down on whose demographics you're interested in and incorporate as many of them as would be relevant. So when we think about age, you want to think about whether you're talking about the age of the gestational parent, or are you thinking about the age of the egg donor or the sperm provider? Sometimes we tend to think about the age of the gestational parent as being important, and it is, because there's vasculature in the uterus that's important, but the age of the egg can be very important for looking at chromosomal abnormalities, right? And there are even some chromosomal genetic conditions and morphologic conditions that are linked with the age of the sperm provider as well. So we want to think about that as we're deciding what age is important, what's relevant within this research question. And then gestational age of the fetus can be important, particularly if we're looking at an exposure to the fetus. We want to know gestational age of the fetus at the time of exposure, and then also gestational age at birth, right? And that exposure time period is pretty critical, because we know that the fetus or the blastocyst is undergoing a whole bunch of changes really at the beginning of pregnancy, and has most of their organs formed by the end of the first trimester, right? And then exposures past that point might not lead to major organ changes or limb changes, but instead more changes in functionality. So that's important to think about as we're calculating age, right? What age matters. One thing to bring up, which relates to my term about using gestational parent and pregnant person, is what we mean by sex and gender, and we need to differentiate those. So historically, that was an easy variable, right? It was dichotomous. There were just, like two options, and this was really easy to figure out. But it's not always easy to figure out. So it used to be one of the ways we would do data cleaning, right? Is if someone appeared as male within a pregnant database, we would say, well, that can't be right. It actually can be right. So it used to be in old medical record systems that you couldn't open a first OB visit even in a male's chart. Now, Epic, which is, I think, the second largest electronic health record, has the ability for in a man's chart to open up a new OB. So that gender identification doesn't necessarily equate with genital anatomy or the having a functional uterus, right? So we want to differentiate those in our gestational parents. Now, when we think about our newborns, that's something we have to think closely about as well. So it used to be babies came out, you looked, you decided they look like a girl or they look like a boy, and that's what got coded into the chart. It is a rare condition, but there are individuals who have a normal female morphology. So they have normal female genitalia, but genetically are XY. And now that we have all this fetal testing, right, those individuals may be, we may know them in the system because of the difference in their genotype that we got through non-invasive prenatal screening or invasive prenatal screening, and what their genitals look like. So that's something that we should think about as we're setting up what gender and sex looks like for infants. Also, just a note on what race means. We collect it a lot, we analyze things by it, we control for it sometimes, but it doesn't really necessarily, like we aren't being clear as to what it means, right? Why is it so important here? Are we measuring exposure to societal pressures like racism? In large part, we are. But if that's what we're measuring, we're neglecting a whole group of individuals who might experience societal pressures who we aren't counting. So for instance, let's take Nashville. We have one of the largest Kurdish refugee populations in the United States. During the Iraqi War, large numbers of Kurdish individuals settled in Nashville. Those individuals who identify as women wear hijab. They have experienced a lot of discrimination on the street due to their head covering, due to their life. And so if we're trying to collect data on their societal pressures, they appear as white non-Hispanic in census data. They appear invisible in our data, despite the fact that they're experiencing that stress. So if we want to measure societal pressures and racism and xenophobia, we need better measures to do it, because race alone as a demographic variable doesn't do it for us. Sometimes when we're measuring race, we're also measuring geography, because if you go back to 1950s or so with redlining, which is when, you know, there were areas where different people of different demographics were permitted to buy houses and live, that still exists. It still is prevalent in housing markets that groups of people live in certain areas. And not only do they geographically live there, but they have different exposures based on their geography. So in many major cities, the interstates went through historically Black neighborhoods. Those are still historically Black neighborhoods in many cities. And those neighborhoods have greater exposure to air pollution because of the increased interstate traffic near their homes. In addition, those areas are less likely to be well funded in education because we have local payment for education. So those are things that we can also be having when we're using a race variable to mean geography, right? So as we think about that variable, we want to be very careful as to, is it even meaningful? What does this mean? Particularly in a society where we have large numbers of people marrying individuals or childbearing with individuals who don't look anything like them. So what does that mean for a fetus if we're going to say this fetus has this particular census-based race category? It's kind of meaningless because that fetus actually has a lot of cultural and genetic diversity even within them, right? So as we think about that as demographics, then we can also think about some issues that may come up when we're trying to think about our exposure, right? We talked about how gestational age affects susceptibility to exposure, right? There's also lots of interactions between genetics and exposures that can be complicated by rare outcomes, right, among pregnant individuals. So there's this train wreck example where I had a friend of mine call me. She's from my hometown. My hometown had a train overturned with a very virulent chemical. She's like a mile away from where the train has overturned, and she's like 7 weeks pregnant, right? So there's so many different variables there. So the individuals who are up against the train are exposed. How many of them are pregnant? How are we going to track those outcomes? How are we going to track their dose, right? So then she goes on to give birth to an ostensibly healthy baby boy who then didn't talk until he was about 3.5. And she comes back and she says, do you think it was this exposure to this chemical from this train? Well, that's really difficult because there's also that interaction with genetics, right? Was that particular fetus more susceptible to the chemicals from the train? Or, and here's one of the next bullet points is, were there multiple variables that went into that? Is the child having a speech delay because of exposure prenatally, or is it because she was 41 when she gave birth, right? Or had a health system issue? So that's something that we want to look at and control for as we're getting into big databases. One other issue is data aggregation across systems. So even looking here at Vanderbilt and a change from one EHR to another, sometimes our fields are slightly different, or sometimes the fields are presented to patients or to providers in a slightly different way. That means they may not be quite measuring the same thing. So how we aggregate data and how we make sure that we're getting great seamlessly collected data where this data set means, you know, that the variables mean the exact same thing as this data set, or finding ways to transform them so they do align well. And then also when studying exposures, we want to make sure we have a good measure. And I wish I could say we had better measures than we do. A lot of times fetal effects of fetal exposures aren't visible at birth, right? And without these large data sets, we don't have the ability to track them for years and years. I think now with the EHRs the way they do, we're going to have better data there. And if you look at a lot of studies, what they end up using as measures are morbidity and mortality. And those aren't the only meaningful measures, right? Like my friend's son had no morbidity, he had no mortality, but he wasn't speaking at age 3. Those things are meaningful to individuals, but can be harder to capture. And I think one of the things we really do want to do is to get outcome variables and to get measures that are meaningful in healthcare provision, and also to the people that will be using that data for their health. Another potential confounder in perinatal research that's actually a pretty big deal that we really have to think deeply on is selection. So there's substantial cohort attrition from the time of an anticipated conception to live birth. And a lot of times we're just using live births, right? So there's kind of a live birth bias there, right? And that's because of many, many reasons, right? Conception is super difficult to measure. There's really very little way to measure conceptions. And then by implantations, we can measure, right? The person has a positive pregnancy test. Only about 1/3 of implantations reach viability. Oh, wait, yes, no, sorry, 1/3 of them do not reach viability. And these losses are non-random, and they in themselves may be an outcome. And may be an outcome due to genetics or due to developmental abnormalities. These losses also may be related to fetal testing and subsequent decision-making. So now with the rise of in vitro fertilization, people get multiple opportunities to change the ability of to only implant normal blastocysts, right? So they are able to take one cell off, do some pre-implantation testing, and decide not to implant embryos that aren't viable, right? That have abnormal chromosomal makeup. But that's non-random, so that may in itself be an outcome that we need to study. Over time, this cohort attrition, right, as babies are, as blastocysts don't make it to be embryos, as babies are born preterm, those kind of things result in substantial attrition of the cohort. And it changes the number of individuals at risk for a particular outcome related to a particular exposure. So as we form cohorts, it's really important to know when to form the cohort. So in Project 2, we actually have 2 aims. One is focused on live births, and those infants all have charts, right? And then the second aim is actually focused on overall pregnancy outcomes in order to be inclusive of the miscarriages, inclusive of preterm births and stillbirths, because that's meaningful to the individuals we serve, right? And then there's a whole new level when it comes to perinatal care, in that birth is more than a procedure. So people aren't always getting evidence-based care, and they're not getting evidence-based care for a large number of reasons. One of which is that there's it's a personal moment, right? In a lot of cultures, birth is a rite of passage. People often have really strong feelings about their birth experience, right? If you look at data on procedures, right, decreasing variation is a good thing, right? There's large amounts of data on eye surgeries, for instance, joint replacements. The less variation you have, the better, right? Because then you have people who are at a higher level of performance. That's not the case with birth. And you can kind of think about it like nobody posts their eye surgery on Facebook, but people pay for birth photographers, right? That's important to them. It's a big moment in their lives. They're welcoming a new family member. And so people come in with desires for physiologic birth or desires for intervention that change healthcare considerably and have downstream effects on outcomes. So that's something to think about. And those are, again, non-random. It's not like someone who wants a physiologic birth and doesn't want any interventions is just as likely to walk into hospital A as somebody who is totally fine with all the interventions. These individuals who have particular needs may intentionally seek out different facilities in order to get the birth that they want. I wish I could say that even outside of information about a person's desires for their birth experience, that we did a good job of providing standardized perinatal care. And that's just not the case. There's not one single model of prenatal care. There's a whole bunch of models out there. And in fact, right now, the American College of Nurse Midwives is doing American College of Obstetricians and Gynecologists is doing a big deep think and moving away from the model that we've had since the 1950s and putting in a new, more elastic model that's more responsive to social and structural determinants of health and really incorporates a lot more telehealth. And that's going to be rolling out soon. There's also group models of prenatal care that may influence outcomes. So that can be a confounder as well. There's also a lot of different providers in the United States. So there's maternal fetal medicine specialists. There's obstetrician, I'm sorry, that moved for you too. There's obstetrician gynecologists and there's midwives. And the different providers have to do with gestational parents' choice, right? The pregnant individual's choice, as well as health status. So there's multiple pressures in on the selection of that provider. In addition, location is super important in perinatal research. Urban versus rural residence is something that comes up a lot as a confounder, particularly individuals who live in rural areas where there's not a hospital that provides perinatal services. There's a really good study that was published in Health Affairs that showed that the rate of preterm birth rises when the community hospital that stops providing maternity care services. So rural residents can affect health outcomes. Also, different hospitals have different rates of use of different procedures. So this is a graph of the variation in cesarean birth rate in US hospitals in 2009. You can see the huge amount of variation there. That's incredible. Some of that has to do with the fact that regional centers draw higher risk women from the surrounding areas and they give birth at the regional hospital. So you would expect that hospital to have higher rates and the surrounding area to have lower rates due to the risk status of the birthing parent, right? Big differential. However, some of this variation is not explained by that. It's just non-standardized care, maybe increased use of cesarean birth by key providers in certain hospitals there. So that's something to keep in mind too. Also, there are a lot of places to give birth in the US, hospitals, birth centers, homes, and those all have different rates of use or availability of intervention. And then also different characteristics of people who choose to give birth in those locations, right? So those are all things to think about as we sculpt perinatal questions and we look at the big perinatal elephant, right? This is in part just to get us started talking about that. I think it's super important to bring all of our knowledge together to generate meaningful data to answer these super important questions. The United States so lags behind other developing countries and other developed countries in big, big ways in terms of maternal morbidity and mortality, perinatal morbidity and mortality, particularly drawn across racial and ethnic lines, and beyond morbidity and mortality in well-being and how individuals do after giving birth. So I'm so glad that MPRINT allows us to have team-based approaches to study things so that we can get more accurate and more meaningful data that's more reflective of what's going on, what the real reality is of healthcare in the US, because everybody deserves the best possible start and no one should have their health status suffer as a result of giving life to someone else. So I'm going to stop sharing my slides in part so I can see the chat and see if anybody has any questions because we're done a little bit early.
Great. Thank you, Dr. Phillippi, for such an interesting talk. Please feel free to share your questions in chat or raise your hand and we can unmute you to ask your question to Dr. Phillippi. I do have a couple of questions to get us started off on our discussion. One of the things you talked about was following the overall pregnancy, not just the live birth, right? But how do you actually identify and capture pregnancies that may end early? Women may not even report to the hospital for them. So how do you evaluate those when they're not captured well in a medical record?
Yeah, they aren't captured well. And that's actually a pretty big issue. So HCUP data doesn't include a lot of those miscarriages, right? Because there's no hospital stay that goes along with them. So some researchers have used when a chart has been open and closed for a pregnancy episode. And so the closure of a pregnancy episode, so you can use some outpatient coding to pick those up. But there are ones that we won't pick up at all, right? That we need to acknowledge that some people miscarry even before they're able to seek perinatal care, which is kind of hard, and I think that was particularly true in data surrounding COVID. Like people felt like I'm otherwise well, I'm not going to go to like a health facility where I might get COVID. I'm just going to wait this out. And then often they would have a miscarriage prior to even being seen. But there are some ways to use billing codes for end of a pregnancy. So you can see ones where they've started prenatal care and then did not continue.
Great. And I was actually going to ask about how COVID has impacted the research in this area and as well, and what changes you have seen due to COVID.
There has been a big surge in maternal mortality in the US and around the world due to COVID. Maternal mortality is very rare, so rare that it's measured in like 1 out of 10,000. And we've seen a large increase in part because pregnant individuals did not do as well with COVID. So that's one of the big things that we know we're going to see in the data once it comes out. But we also saw a huge move to telehealth, right? Like big and fast. But that isn't all bad, right? Because who needs, like it's great that we handed out blood pressure cuffs and ways to listen to your baby's heartbeat for individuals, because then some individuals who are really juggling a lot in their lives, like they have existing children or they have a busy work schedule, could take their blood pressure and report it back to us. They didn't have to drive all the way in and sit in a waiting room. They could have their quick 10-minute telehealth visit while their kids are watching a video. So I think some of the good parts of telehealth, I hope we keep. And there's this new prenatal model that's being rolled out known as MyPath that has more telehealth visits and actually has this delineation of here's where you actually need someone to come in and do something to them versus here's where you need to give them education and check their blood pressure. They don't have to come in.
Great. And I guess similarly, as the previous question is capturing data on home births and how has that worked into things, and similarly, I guess, my experience with some of our reproductive endocrinologists who do the in vitro fertilization, they're not connected to our electronic health records at the hospital either, and they don't follow outcomes. So, I found it interesting you talking about the difference between, the birth parent and the genetic parent, right? The egg donor. And, how do we follow up on these and what needs to be done to improve, I guess, our access to data in the future?
Yeah, I think we need to be doing a better job of adding that data into the chart. Right now, that the idea that someone uses an egg donor is usually in free text, right? Because there's not a radio button for it. So it's not easy for me when I have someone come in and I'm doing an intake for them, for me to easily mark that this was a donor egg. But that's a big deal, right? Like genetically, then this child may not have the same risk of cleft lip or palate, for instance, that their mother did. So I think we could do a better job of having better fields to collect this data so it's easier to generate the data later. And I think we could do a better job of knowing where to look for data, right? So one of the things I love about the imprinting that I'm on is that we have people who are entering the data. We have people who are, really looking at moving healthcare data into the data fields. And then we have people who are just pure data. Like they just know the code numbers for that variable. And so I think those kind of collaborations are going to be great as to doing better measurement. Oh, and home birth data. I didn't answer that one. That one is trickier. And there's 2 ways to get at home birth data. So there's birth certificate data, but the peril of birth certificate data is it only records where the baby came out, not where they started out. So unfortunately, if you have somebody who starts out planning a home birth, something does not go right, they often transfer into the hospital, the baby actually comes out there. That's where the birth certificate is recorded for the location of birth, not the intended location. Some states have changed to have a field for intended location of birth so that we can pick up those intrapartum transfers. There's also a database known as MANA stats, which a lot of midwives who are not nurse midwives, who are lay midwives, so they have a different training and background, are required by state law to input data for every pregnancy they care for into that database. And so that database has been used to study home birth care processes and outcomes. But we could definitely do a better job, right? Because those people aren't in our big medical records database.
All right, looks like we do have a question here in our Q&A. Are babies of the same gestational age who are born vaginally do they differ physiologically from those who are born by cesarean section? And then if so, does it impact the pharmacokinetics or pharmacodynamics?
Okay, so that's I'm going to give you a little bit more complex answer to a good and simple question. Physiologically, they only differ in that they differ in a couple of ways. One is you have to know whether the individual labored first and then gave birth, because when the individual starts to labor, that increases the cortisol within the baby. So the baby gets a little stressed by that labor. And that's not a bad stress. It's kind of a good stress because it gets their lungs ready. So cortisol is part of the lung maturity cascade. So knowing whether they had labor helps you have a little bit more info about how their lungs are behaving. In addition, babies that are born vaginally, you can think about the difference between being squeezed in your mother's pelvis. If I have fluid in my lungs and I am squeezed that hard, that fluid is going to come out my mouth. Babies that are born by cesarean don't have that same squeeze to get fluid out of their mouth. So they do have a higher rate of like a transient respiratory distress. But as far as the amount of fluid within their bodies, that's the same between the two. There is some discussion about the amount of IV fluids the laboring person has and how that influences initial newborn weight and how much weight loss becomes physiologic with that. So we are seeing some individuals talking about people who've been in labor a long time received a lot of IV fluids. Their babies may actually have more of those fluids on board in their bodies when they're born. So that's a little bit different in pharmacokinetics, but I don't know that it's been well measured. What was that second question you gave me too?
It was the same question,
Oh,
just
okay.
said twice, so thank you. Great, so an excellent talk. Are there any other questions for Dr. Phillippi? If not, I will thank you for joining us today and also invite you to attend our April MPRINT webinar series on April 11th at 2 p.m. Eastern Time. The topic will be a bioethics roundtable discussing anything related to maternal and pediatric pharmacology studies. We'll feature Drs. Peter Schwartz, Bethany Johnson, and David Haas, who have some expertise in bioethics, regulatory affairs, and obstetric pharmacology studies, respectively. I invite you, if you have questions relating to bioethics that you're interested in hearing them discussed, to feel free to share those through our LinkedIn page at MPRINT Hub, or email them to me directly at squinney@iu.edu. With that, we will thank you for joining us today, and we look forward to seeing you in the future. Thank you.
Thank you.